dear viewers and students. Today topic of discussion is hemorrhoids or piles. So hemorrhoids are dilated plexus of superior hemorrhoidal vein in relation to anal canal. The alternative names are rectal lump, piles, lump in the rectum. So it is defined as dilated or enlarged veins in the lower portion of the rectum or anus. Causes for hemorrhoids could be primary or secondary. The primary causes include the standing position of the human being, as the blood has to flow against the cavity. Anatomical factor, as the veins passing through the submucosa of the rectum get constricted during the act of defecation. Another reason could be familial or genetic factor, constipation, diarrhea, obesity, heavy lifting and pregnancy. Secondary causes for hemorrhoids could be the carcinoma of rectum by blocking the veins, can produce back pressure and can manifest as piles. Portal hypertension is uncommon cause of piles. Pregnancy is the reason for piles due to compression on superior rectal veins or due to progesterone, which relaxes smooth muscle in the wall of the veins, can cause hemorrhoids. There are three prominent cushions: left lateral, right posterior and right anterior, located at the 3, 7 and 11 o'clock position when patient is lying in lithotomy. Superior hemorrhoidal artery gives two branches on right side and one branch on left side. Hence piles are two on right side and one on left side. Hemorrhoids are of three types depending upon the location of hemorrhoids. First is internal hemorrhoids, which are above dentate line covered with mucous membrane. Second is external hemorrhoids, which are at anal verge covered with skin. And third is interno-external, which have both the varieties together. Internal hemorrhoids are further classified into four grades. Grade first, where painless bleeding occurs with no prolapse. In grade second, there is prolapse on defecation that reduces spontaneously. In grade third, prolapse that has to be reduced manually. In grade fourth, there is permanent prolapse. Here, diagrammatically, all the four grades have been shown in this picture. Clinical features of internal hemorrhoids include painless bleeding. Fresh bleeding occurs after defecation, that is, splash in the pain, and that may result in chronic anemia. Most of the patient complain of constipation. There is discharge of mucus and irritation of perianal skin. Pruritus is a common feature. There is anal itching, pain during bowel movements, bright red blood in the stool, rectal prolapse while walking, lifting weight, thrombus, extreme pain, bleeding. That is a sign of a systemic illness in case of strangulation. Clinical features of external hemorrhoids include olive-shaped blue cutaneous swelling along with itching around the anus or rectal area. There is pain around the anus, lumps are formed near and around anus, and the onset is sudden. Focus on the differences between internal and external hemorrhoids. Internal hemorrhoids lie above the dentate line. They develop from embryonic endoderm and are covered by columnar epithelium of anal canal, and they are not supplied by somatic sensory nerves, so cannot cause pain. Whereas external hemorrhoids lie below the dentate line, develop from embryonic ectoderm covered by squamous epithelium, and are supplied by cutaneous nerves. Complication of hemorrhoids include strangulation, thrombosis, ulceration, gangrene, portal pyemia, fibrosis, and severe hemorrhage. There could be chronic anemia, and rarely massive bleeding can occur due to portal hypertension. Ulceration and secondary infection can also occur. Investigations per rectal examination is done mainly to rule out carcinoma rectum or other causes of bleeding per rectum. Hemorrhoids cannot be felt by rectal examination unless they are thrombosed or fibrosed. Second way is proctoscopy. As the obturator is removed, piles prolapse into the lumen of proctoscope as cherry red masses. Sigmoidoscopy and proctoscopy are done to rule out proximal cancer. Treatment of hemorrhoids include from simple reassurance to operative hemorrhoidectomy. Treatment are classified into three categories. First is dietary and lifestyle modification. Second is non-operative or office procedures. Third is operative hemorrhoidectomy. If a prolapse outside present with pain in the perianal region, piles gripped by internal sphincter result in venous congestion and edema. In such patients, they are recommended for saline dressings to reduce edema, along with local lignocaine jelly applications with metronidazole is given. Patients are recommended for warm baths, high fiber diet, to take adequate fluid intake. Stool softeners are given along with topical analgesics, and they are asked to maintain proper anal hygiene, as unhygienic conditions may result in sepsis, secondary infections, and ulceration. Surgery for hemorrhoids include the sclerotherapy. Injection of sclerosant is given. 5% phenol in almond oil is injected into the submucosa to decrease the vascularity and increases fibrosis. It produces aseptic thrombosis of pile mass and is indicated in grade 1 piles. Injection is perivascular. Second procedure is Barron's band application. It is indicated for grade 2nd and grade 3rd hemorrhoids, wherein bands are applied at the neck of hemorrhoids. It causes necrosis and thus piles get fibrosed. One or two can be banded at a time. Disadvantage is that it results in bleeding. Third procedure is cryosurgery, where the liquid nitrogen is applied to pile masses which coagulate the tissue. Procedure is painless and there will be continuous mucus discharge for 3 to 4 weeks. Beside this, ligation and excision of hemorrhoids is done by using open technique and closed technique. Open technique is called Milligan-Morgan operation, where the anal mucosa and skin are left open to heal by secondary intention. The closed technique is called Hill-Ferguson, where the wound is sutured.